After a great short time of the liver surgery, now let's go on to the lecture session. Let's welcome Dr. Zhang Shujun to host the next part of the lecture. Thank you for the Dr. Hayati to supply the so excellent the surgical demonstration. Thank you, everyone.
Hi, hello everyone. This is Shujun. Thank you very much, and it's really my honor to attend this meeting. I'm a doctor from Wuxi Affiliated Hospital of Suzhou University, and I'm really grateful to be attending this meeting. And now let's welcome our first speaker, Dr. Maxime Xiali from Clinique du Paris, France. His topic is how to learn UBE to colic. What's the common mistakes of beginners? Let's welcome. Thanks.
So I am Dr. Maxime Xiali. So do you see my slides? Do you see everything? It's okay?
Yes, we can see.
Okay.
Thank you.
So my topic is you learn UBE surgery, and now you try to learn your colleagues to do this surgery. I began UBE surgery more than 1 year ago, and now a lot of colleagues in France want to learn to start to do this surgery. So like Hippocrates says, we need to learn to our colleague how to do this kind of surgery. So my story, 15 months ago, Dr. Zhang made me a 3 hours course, and I did today after this 2 discectomy. Now I did more than 300 cases in 14 months, but my story is not reproducible. I did it, but my colleagues, it's more difficult for them. Maybe I was lucky, but today it's we have a big problem to find a good way to learn this UBE to my colleagues. So, how to teach UBE surgery? The first is to create a reproductive, standard technique for discectomy, stenosis, and fusion, and try to make it accessible for them. And after, when you have a clear technique, you need to teach beginners. So, in spine surgery, you have different types of spine surgeon. We have the most difficult for me is neurosurgeon, which have no base of endoscopy. After, orthopedic surgeon with small base, it's more easier. And when you have a good base of shoulder on knee arthroscopy, orthopedic surgeon are more effective to learn UBE. Because UBE is similar to shoulder arthroscopy. Orthopedic surgeons with a background of arthroscopic surgery are more easy to teach because we do a lot of things like triangulation, like move your hand, like this kind of thing. So the first thing is to organize a theoretical course on anatomical lab. We organized the first UBE course a year ago in France. So we have a lot of surgeons came and we try to learn them how to do this UBE surgery. It was a very interesting course, but after this they were a little bit disappointed because it's not enough. So the first thing, at the beginning, they think you have anatomical course, theoretical course, you are ready to begin UBE. No, it's not the case. Some guy, yes, but slides at 5%. So some guys come to my operating room, they are coming. Usually I do 5 to 6 UBE surgery one day. It's easy friendly, I'm laughing, everything is nice. And when they come back home, they say, I must begin UBE, it's very easy. But when they start to begin alone, the first case, almost of times, it's like this. It's catastrophe. So, the surgeon says, UBE don't work, it's not for me. It's for crazy surgeons. It's a waste of time. So, you need to find a good learning process. In monoportal surgery, we have very clear learning process. So in UBE, they need to have a standard process of teaching surgeons. The first is theoretical course, anatomical lab. Visit expert UBE surgeon, My advice, an experienced surgeon should help the surgeon for first case, because a lot of surgeons say it's easy, MCU is very easy. When we begin, it's catastrophic. What the expert UBE surgeon must do when you go to help another surgeon, what's your duty? The first thing, my teacher, Professor Alex, tell me, you must know you go to help someone to another hospital, to another operating room. You must know clearly the case. If you are coming a difficult case, it will be very difficult for a surgeon, very difficult for you. So you need to be clearly, you know the case when you go to help someone. You must check everything: instrumentation, the drill, what do you have in the operating room to have less problems. So the first problem is anesthesia. When you are going to another operating room, the most common problem in France is the blood pressure is like 15, 16, 14. You see nothing, the surgeon doesn't see nothing. And the anesthetist must know that you need less than 10. It's very important, but in not operating room, I'm not lucky like my colleague in Turkey. A lot of anesthesists that high level tension is impossible to do surgery. When you are orthopedic surgeon, you do some knee, shoulder arthroscopy, you know that you need to have less 10 blood pressure. But on neurosurgery, they don't care about this, and it's very difficult to have less than 10. The anesthetist must know this before you come to help someone. On the new patients, I like to have some cure to have it's more easy to do a working space at the beginning. You must speak with guy you want to have intrathoracic pressure or arthropump, but you must know what the surgeon have and what you want to use. A common mistake is to put water at the level of operating theater, and you must check everything because the new surgeon have a lot of things to learn. It's his first to be surgery. You need to use new instrumentation, to do new kind of surgery. And you need, when you go to help someone, try to have everything perfect. Another thing, some guys put fat patients. Okay, it's a very nice idea, but you see some surgeons, they don't be able to cut fascia. They just try to do endoscopy for 2 hours, and there's spinous process. So you need to ask to your surgeon, take easy case. If you don't have easy case, they can wait 3 weeks, 2 weeks, because the most difficult situation when you go to help someone, or you make 4 hours to remove this herniation. I have a case of this kind of situation in my experience. So you need to find good case. The most common problem for beginners is triangulation. A lot of surgeons, when anatomic lab, they say it's difficult to do triangulation, it's difficult. In fact, almost of surgeons, they don't have so much problem to do triangulation. The most important thing is to take your time, because after 10, 15 minutes, you don't find your radio frequency, you don't find your instrument, you want to stop, you need to take your time. The beginners, the most common mistake is to move camera and radio frequency at the same time. And you are totally lost, you don't know what you are doing, and you need, for beginning, only to move camera or instrument. And we have some small thing for all of them, but triangulation is clearly the time when you need to find your way to do it easily. After 20 cases, you do it in 10 seconds. But sometimes when you go to a beginner, you will fight 30 minutes to find his radio frequency. The second thing for beginners, UBE is not an X-ray surgery. First thing, you need to see, you need to have a clear view what you are doing. On X-ray is only for portals. Sometimes you can use X-ray during your learning curve to check where you are in contractile side, something like this. But it's surgery is done by your eyes. The beginners make a lot of X-rays, and the X-ray is not a good friend like usually in a spine surgery. And you are lost by X-rays, or you must try to operate with your eyes or not with X-ray. For beginners, it's clearly a problem. When monoportal surgery, They take a long time to enter the canal, it's difficult. In UBE surgery, it's not a big problem. In this time, a lot of beginners are scared to do a dermal tear. That's why my advice is to go to insertion of video ligament to enter the canal. About the camera, during the surgery, they speak about 0 degree, 30 degrees. I think 30 degrees camera, it's a very good friend to go where you want. You can see, when you turn your camera, you can see on recessus, you can see under spinous process. And I think clearly, 30 degrees camera is a very, very good friend when you do surgery. But for beginners, it's the most common problem when you use 30 degrees, because the scope of camera is moving, they don't see that it's moving, and they become to be lost. The instrument coming up, from down, and they are totally lost. So I think, my point of view, you need to begin with 30 degrees, but you must be very, very aware that the scope can move or you can be lost. But I help maybe 20 surgeons to begin UBE. Almost of times, they have a problem with the 30 degree scope. I think, for a point of view, for a learning curve, you need to begin with 30 degrees. It's better, but at the beginning, it will make a lot of problems for you. Again, when you go to another operating room, you need to check on instruments, because when the guy is begin, maybe he don't have dissector, he don't have hook, he don't have usual instruments. You don't have a rotative Kerrison, you don't have instrument, you need to do UBE. You must check everything. And you need to be sure that you have a good drill. One day I come to an operating room to do one stenosis, the guys say, I don't have drill. So it's a little bit problem to do this kind of surgery. Again, you need to check everything. And like usual spine surgery, a good instrumentation make you do that easier. It's very important to have perfect instrumentation. You don't have surgeries, only small details. You need to have perfect instrumentation, perfect drill. It makes more chance to have a success when you help the surgeon to begin UBE surgery. Now in France, we are thinking to use some plastic models, because we have some surgeons, they did course, they did visiting to see me, they try, they can't do UBE surgery. So now we speak as a company to have some plastic spine for beginners. Another way to help surgeons is to do a virtual simulator. I will speak with a French company next week about this, to help the surgeons. Some surgeons, they are beginning very fast like me. They see one time, next time, we did surgery, like my teacher. He come to my operating room, I did first disc herniation, he did the second disc herniation. But almost of case, it's very difficult for them to learn UBE. It's why they need to have perfect way to learn them this kind of surgery. I think UBE will be a standard, because you have more possibility that monoportal, and think at the end, UBE will take the part. You need to find the best option to learn UBE to your colleagues, because you need to teach them to help them to do this technique. You must try to do reproducible technique, a standard technique, because it's more easy to learn this. I know UBE is very interesting because you can do what you want, you can use the instrumentation, you can do you use your usual instrumentation, but at the end, for beginners, you need to say them how to do a standard surgery. After, they can do what they want. 30 years ago in France, we did the first meniscectomy in Bordeaux. Now, no surgeon do meniscectomy open. I think in the future, it will be the same for UBE surgery. In conclusion, if you think that you are a master in UBE surgery, you know how to do UBE surgery, you need to help your colleague to do this kind of surgery. You need to find the best way to help them. And the most important thing, you need to do personalized support for all surgeons. You have good surgeons, you have guys very easy for them, and you have guys very difficult for them. You need to focalize on the guy which is difficult to learn UBE surgery, to help them during your learner curve, to help them to become a master and expert in UBE. Thanks for your attention.
Thanks for Dr. Maxim Charity's wonderful presentation. And it's really a very nice presentation. And this really remind me a lot of stuff. I mean, when I first do UB surgery. So it's a lot of meaningful points for the beginners. So if any questions, please record it and we will discuss it later. Let's welcome the next speaker, Dr. Yongjin Park from Songjun Hana Hospital, South Korea. He is a member of Korean Orthopedic Association. His topic is beginner's journey of rightful UBE, pitfalls. Let's welcome.
Hello, everyone. Can you all hear me? Hello, everyone. My name is Yongjin Park. I am orthopedic surgeon in South Korea. Today, I would like to talk about beginner's journey of rightful UBE. At the beginning, I would like to show you a case which is unrightful for patient and surgeon. 67-year-old female who had right lower extremity radiating pain. Operation history, she underwent L4-5 decompression surgery 15 years ago. The X-ray shows multiple degenerative change and kyphotic change. And on MRI, L3 for central stenosis and L5S1 central and foraminal stenosis was diagnosed. The surgeon who performed surgery had 20 years of spine surgery experience. Also, he had PLD experience. However, there was no appropriate training for education of UBE. But the surgeon plans for two-level decompression using UBE. Endoscopic view shows only central decompression of ligamentum flavum. Post-operatively, the patient has same preoperative right lower extremity radiating symptom and left side motor weakness occurred, which was normally preoperatively. Medication treatment was maintained for 1 week, but no recovery was found, and surgeon decides to go for follow-up MRI. As you can see, preoperative lesion was remained, and massive hematoma formation was found, with massive back muscle injury. The surgeon underwent revision open surgery, but right side radiating pain improved a little, but left side motor weakness was remained, which was catastrophic result for both patient and surgeon. I started performing UBE surgery 1 year ago. I summarized my UBE journey as a roadmap like this. Last year, March, I first visited Master Son and started my UBE training. Till then, I attended cadaver workshop and many UBE symposium to learn the basics and details of UBE. Always discuss the cases with Master Son and Dr. Mangyu Park and steadily carry out UBE cases. From May 2021 to April 2022, I performed 70 cases and 90 levels in thoracic and lumbar lesions. This is my first UBE case. 79 years old female who had low back pain and both lower extremity radiating pain. On MRI, she had recent L4 compression fracture and L4-5 central stenosis. 2 weeks of conservative treatment, I performed vertebroplasty for L4 recent compression fracture, but she still suffered from radiating pain and decided to decompress L4-5 central lesion using UBE. Total operation time took 4 hours and 40 minutes. Fortunately, her symptom improved dramatically, and despite old age, her post-operative condition was well. After performing first UBE case, I reviewed my surgery and had many thoughts. Why did it take so long? I would like to share my experience from now on. Pearls and pitfalls in UBE. How fast is not that important, but too long surgery can be burden to patient and surgeon. To overcome learning curve, we should know how to save times during UBE surgery. First, reducing bone work time. If enough bone work is not obtained, you have to keep change instruments. This takes time. Second, detach ligamentum flavum in en bloc, not in piece by piece, also can save time and more safe. Third is bleeding control. If the view is not obtained, it is hard to maintain the operation and also high risk of dural tear. To reduce bone work time, you have to get used to endoscopic view of anatomy. It is hard because the landmark is not sufficient in UBE. Also, scope angle is important to maintain appropriate bone work to expose ligamentum flavum. For me, at early cases, I tend to bend the scope toward me too much during bone work. As a result, laminotomy was going contralateral side at first. As you can see in the video, my bone work progressed toward contralateral side, going through the spinous process space part, and eventually exposed the contralateral lamina space fat. We should first find the spinal-lamina junction and start ipsilateral laminotomy. Bone work progressing downward exposes the ligamentum flavum. Finally, we can find midline fissure of ligamentum flavum. After exposing ligamentum flavum, it is important to remove a principle. In this video, I started detaching ligamentum flavum from the midline fissure area. It takes more time to detach it all. More number of times using Kerrison punch will increase risk of dural tear. To save time and for more safety, first remove superficial layer first. After removing the superficial layer, detach the caudal aspect of ligamentum flavum deep layer. Finally, we can remove the ligamentum flavum in en bloc piece using pituitary punch. We always have to keep in mind the basic concepts of UBE. It cannot be overemphasized even though it is mentioned several times. Basic surgical steps of UBE can be summarized in 6 steps. First, making appropriate viewing and working portal is initial step. By interfascicular approach using seriodilator, we can expose the spinal lamina junction. As you can see in the video, this is initial working space. Using radiofrequency device, we make up the working space to find the bone work area. After enough exposure of target bone work area, we start bone work to make true working space. When superficial layer of ligamentum flavum is identified, ipsilateral laminotomy is performed. This step is based on the UBE discectomy, so after ipsilateral laminotomy, ipsilateral flavectomy is done. After a second seg is exposed, we gently retract the root and remove the disc. For bilateral decompression, before ipsilateral flavectomy, we should do contralateral side bone work and remove the ligamentum flavum after enough bone work is done. In the literature review, several complications in UBE is reported, and among them, dural tear and epidural hematoma formation is most common complications. To go on our journey of UBE, we have to know how to reduce such complications. First, we have to be aware of anatomical risk factors, and then, through continuous practice, overcome the technical risk factors. Finally, meticulous bleeding control. To avoid iatrogenic dural tear during UBE, we have to keep in mind of anatomical risk factors. Typically, these 4 structures are important. Posterior epidural ligament is usually attached near midline fissure area of ligamentum flavum. During flavectomy, there is risk of making dural tear. Also, posterior lateral segment of epidural ligament is found when we gently retract the sacral sac to expose disc space. For severe spinal stenosis patients, under ligamentum flavum deep layer, there is thick epidural membrane, making us mislead to dural tear. Dural folding is also a risk factor. When we use calcium punch, risk of folding part intervening to punching area can make dural tear, so caution is needed. For technical risk factors, clear vision is always important during UBE. To make clear view, bleeding control is important. Working with poor visibility is very dangerous. Handling of instrument, especially calcium punch and burr, takes a large proportion in learning curve of UBE. This needs a lot of practice. And most caution needed is using burr after removal of ligamentum flavum. Always remain deep layer of ligamentum flavum if you seem to do more bone work. This case is my incidental dural tear case. 77-year-old female has severe left side lower extremity radiating pain. MRI shows severe spondylolisthesis and needed fusion surgery. However, the patient had not enough conservative treatment period and wanted to take surgery desperately due to severe pain. So I planned L45 ULBD and explained her that she needs additional fusion surgery later. Spinal canal was very narrow, and during laminotomy, incidental dural tear occurred. You can see the rootlets are coming out. I gently repositioned the rootlets with Freer and used taco seal sealing technique to seal the durotomy site. Post-operatively, the patient improved preoperative symptom, and after 1 week of bed rest, there was no symptom due to dural tear. Epidural hematoma formation is another common complication after UBE. Symptomatic hematoma formation incidence is 0.1 to 0.2%. Kim reported risk factors causing post-operative spinal epidural hematoma, and they are female patient, old age, preoperative anticoagulation medication history, and use of water infusion pump during UBE. When we take a look at vascular anatomy of posterior aspect of vertebra during approach, main bleeding focus is superior and inferior articular artery. When severe bleeding causes blurred vision, we have to try to coagulate these two vessels first. After laminotomy, initial bleeding site is epidural vein near cranial attached site of ligamentum flavum. As you all know, many branches of epidural vein is located near there. There are various methods controlling bleeding during surgery. Most commonly used device is radiofrequency device, which is very effective controlling vessel and muscle bleeding. Patients having osteoporotic bone shows tendency of bone bleeding more than other patients. Applying bone wax is very useful controlling bone bleeding. And for intractable bleeding, gelatin thrombin-based flowable topical hemostasis agent such as Flosil is very useful. This case is my first hematoma revision case. 77 years old female suffering from back pain and severe both lower extremity radiating pain visited our clinic. MRI shows recent L2 compression fracture and L12 spinal stenosis. I performed L2 vertebroplasty and L12 ULBD at single day. However, the patient shows severe pain after operation, and follow-up MRI showed hematoma accumulation at this decompression level. Next day, revision operation was done. Large amount of hematoma collection was found, and after removing hematoma, you can see the active vessel bleeding. I use hook-type radiofrequency device to control it. After controlling the vessel bleeding, bone bleeding was controlled using bone wax. To make sure, I apply Flow-Seal and compress for 1 minute. And after that, I washed out everything and check the bleeding again. And the drainage was inserted. The patient showed improvement of symptom, and follow-up MRI showed decompressed decocep. From now on, I will show you several cases which I think application of UBE is very beneficial for this kind of patients. First is cystic lesion treatment by UBE. 30-year-old male patient had right lower extremity tingling sensation. The MRI shows L4-5 discal cyst formation. Endoscopic view shows discal cyst after retracting nerve root, and after discal cyst excision, nerve root is free. Follow-up MRI shows complete removal of discal cyst. In the video, after gently dissecting adhesion between nerve root and cystic lesion, you can see the hemosiderin deposit coming out from the discal cyst. Next is multiple spinal lesion treatment by UBE. 66-year-old female has severe both lower extremity radioactive pain and shows sciatic scoliosis posture. As you can see in the photo, the patient cannot stand straight and maintains right side bending posture. On MRI, L3-4 central stenosis and L4-5 foraminal cyst is found. Before operation, I thought it would be tallow cyst and decided to decompress the extraforaminal area only. Through foraminal approach, bone work was done at isthmus and accessory process area, and foraminal ligament was exposed. After removal of foraminal ligament, you can see the cystic lesion around the nerve root. Fortunately, it wasn't tallow cyst and was able to remove, and nerve root was free. For L3-4 central stenosis, ULBD was done. Follow-up MRI shows sufficient decompression of stenosis lesion, and foraminal cyst was also removed. Post-operative posture was corrected and was able to walk straight. The operation video shows isthmic approach. After bone work, foraminal ligament was exposed. I continued the bone work to expose more, and you can see the epidural fat area. I gently used the free air to detach the foraminal ligament. And after removing the foraminal ligament, this is the cystic lesion that was shown in the MRI. I used the free air to gently dissect the adhesion area, and I used the radio frequency device whether it was continued to the root area, but there was no response. So using pituitary punch, I gently removed the cystic area. This case was, next case is 74-year-old male who had both lower extremity identity pain with neurologic claudication. The MRI shows L3-4-5 central and lateral recess stenosis. Starting from lower level L4-5 and L3-4 ULBD was done. Follow-up MRI shows fully decompression of stenosis lesion in L3-4 and L4-5 level. This case was difficult to make decision of operation since patient was old age and had multiple lesions. General condition was not bad and the patient wanted to go on operation, and I decided to perform 3-level decompression. X-ray shows collapsed coronal valence and also degenerative kyphosis. MRI shows central and foraminal stenosis in L345S1 level. Starting from L5S1, ULBD was performed. Endoscopic view of decompression of L45 and L34 level. Total operation time was 3 hours and 30 minutes, and follow MRI showed well decompression of DECA-SEP. Last case is adjacent segment disease treatment by UBE. 74 years old male had right lower extremity radiating pain and motor weakness. He underwent L345S1 fusion surgery in other clinics 6 years ago. MRI shows severe stenosis lesion in L23 level. Instead of fusion extension, I decided ULBD at L23 level due to poor general condition of the patient. Scar tissue and soft tissue adhesion was found, and after bone work, exposed ligamentum flavum degeneration, and the degeneration was very severe. After decompression, we can see multiple vessel engorgement around dura. Follow MRI shows well decompression and patient motor weakness improved. To summarize my presentation, first, I recommend for beginners to learn UBE appropriately. Invest your time in training center and you will never regret your time. Next, don't be in a hurry. Move at your own pace, step by step. Finally, prepare A to Z before you start first UBE case. If you prepare for all possible situations, you won't panic and finish your case successfully. Thank you for your kind attention.
Thanks, Dr. Yongjin Park, for the very nice presentation. Actually, this presentation really reminded me a lot of things. I found I had a pretty much similar learning procedure with Dr. Yongjin Park because I had my first UB surgery just 1 year ago, pretty much similar with Dr. Yongjin Park. But I think that Dr. Yongjin Park is going further than what I'm doing right now because I have never done any fusion surgery right now. But I can see that from the presentation, Dr. Yongjin Park is doing pretty nice work on that. Anyway, let's just welcome the next speaker, Dr. Dong-Han Kim, UB consultant spine surgery at Park Won-wook Hospital, South Korea. Dr. Dong-Han Kim is a UB reference doctor and a global trainer at Endospan Max. His topic is prevention of post-operative synovial cyst, ligamentum flava deep layer saving. Let's welcome.
Thank you for introducing me. Nice to meet you. My name is Dong-Han Kim. I am a neurosurgeon in South Korea. I'm working at a Baonon Hospital, Busan in South Korea. For me, it's a great honor having opportunity to present on ISUBE in Turkey. Thank you for inviting me as a speaker. My topic is a ligamentum flavum deep layer saving technique to prevent a post-operative synovial cyst. ULBD, unilateral laminotomy, and bilateral decompression is a standard surgical technique for lumbar central stenosis. As I know, ULBD is firstly described on the text Minimally Invasive Spine Surgery in 2007. For spine surgeon, ULBD is a basic surgical technique and also commonly encountered surgical technique. Through the efforts of Dr. Song and many senior doctors, at present, most degenerative spinal disease can be treated by using UBE. In lumbar area, from ULBD to foraminotomy and fusion. In cervical area, from foraminotomy to single or multiple level ULBD. In thoracic area, relief and hard disk can be removed by using UBE. If we want to convert surgical paradigm from open microscopy surgery to UBE, Not only similar surgical results is needed, but also the rate of postoperative surgical complications are lowered. Postoperative synovial cyst is one of the surgical complications. This figure is from Journal of Clinical Neuroscience, published in 2012. On preoperative MRI imaging, there is severe central stenosis on L5 level. On the immediate postoperative MRI imaging, precardium is well decompressed, but there is widened facet joint gap and high signal intensity. After 10 months later, there is a postoperative synovial cyst on the left side. I reviewed some articles to find out the pathology and mechanism of postoperative synovial cyst. This article is published on Journal of Clinical Neuroscience in 2012. Barcode et al. Reviewed 201 laminectomies in a single institution. On a cervical and thoracic lesion, there is no synovial cyst. 10 postoperative synovial cysts are occurred on lumbar lesion. Incidence rate was about 8%. Average interval to development of cyst is 26 months after operation. In conclusion, the author reported that the formation of synovial cyst after laminectomy may be due to the removal of the ligament flabella that normally lines the inside surface of the facet joint. This article is published on Journal of Neurosurgery in 2017. Bruder et al. Reviewed the results of long-term follow-up after surgical treatment of 141 cases in a single center and literature review of 2,900 degenerative spinal cysts. In conclusion, the author organized the mechanism of synovial cyst. Degeneration process and excessive joint mobility leads to herniation of synovium, and traumatic changes, such as postoperative situations, may destabilize facet joint and ligamentum flavum. As you know, ligamentum flavum is composed of superficial and deep layers. Thick superficial layer attach anteroventral surface of cranial lamina to dorsal surface of caudal lamina, and deep layer lining inner surface of thick superficial ligamentum flavum. It extends laterally, lining inner surface of the facet joint capsule. The purpose of ligamentum flavum deep layer staging technique is not to expose facet joint space. Remove medial portion of inferior articular process and medial edge of superior articular process. Do not remove deep layer of ligamentum flavum. I will show you intraoperative video. This case was a UABD on L5 level. This video contains only left side laminotomy and left side ligamentum flavum deep layer was saved. Surgeon stands on the left side of the patient. 9 o'clock is cranial, 6 o'clock is lateral left side, 3 o'clock is caudal, 12 o'clock is midline, and this is midline cleft of the ligamentum flavum. So ipsilateral laminotomy was already done in this video. I split superficial layer and deep layer of the ligamentum flavum by using free alligator. After remove superficial layer of the ligamentum flavum, upper portion of the caudal lamina and medial edge of the SAP is exposed. Then remove upper portion of caudal lamina using kerosene punch, and medial part of SAP can be removed using osteotome. In this point, only remove bone fragments, not ligament flavum deep layer. Then we can check lateral side of the fecal sac and traversing root. Compared to preoperative MRI imaging, fecal sac is fully decompressed. There is no significant changes on the facet joint, no widening of facet joint, Also, we can check deep layer of the ligament flavum, which lining inner surface of the facet joint. In our hospital, from June 2021, we have done ligament flavum deep layer saving technique in some ULBD or laminotomy cases. The number of cases is small, so it's meaningless to compare the incidence of postoperative synovial cysts between groups. But if we check the results of ligament flavum saving patients group, there is no facet joint gap differences between pre- and postoperative MRI images. There is only one case which the difference is 1 millimeter. There is no significant differences on this type and listhesis of operative level. Even though there is remaining ligament flavum, the dissect area is fully expanded after surgery. The purpose of ULBD or laminotomy is decompression of neural tissue. In this surgical process, we have to minimize damage to preoperative anatomy. In this aspect, if we save the deep layer of ligament flavum, the incidence of postoperative synovial cyst can be minimized. UV has many advantages such as clear visual magnification and easily approach deep area of anatomy. So surgeons can realize skillful surgical tips easily using UVE. Thank you for listening.
Thanks for the nice talk from Dr. Dong-Ken Kim. If you have any questions, you can leave the question to the Zoom platform and we can discuss it later. Now let's welcome the next speaker, Dr. Seung-Jo Lee, the current director of Nano Hospital, South Korea. His topic is surgical resection of cervical intradural extramedullary tumor using UBE, the world's first spinal cord tumor surgery using a spinal endoscope. It's a really very nice topic. Welcome.
Can you hear me?
Yes, we do.
Okay. Nice to meet you. My name is Seung-Jo Lee, an orthopedic surgeon majoring in spinal surgery in Korea. Today, I will introduce surgical management of cervical intradural extramedullary tumor using UBE. It was announced by UBE Symposium in Korea around November 2021, and I'm sure that it is the world's first spinal cord tumor surgery using a spinal endoscope. Spinal cord tumor can be divided into extradural and intradural tumor around the dura. Extradural is 60% and intradural is 40%. Intradural tumor is also divided into extramedullary and intramedullary tumor. Extradural tumors are mostly metastatic tumors and occur mainly in the vertebral body. So the intramedullary and intraosseous tumor are difficult to operate on due to their high levels of malignancy. So what we are aiming for is IDEM. The representatives of IDM are meningioma, schwannoma, and myxopapillary ependymoma. In the United States, there are about 5 to 10 cases per 100,000 people, so it's a little rare disease. Starting with the most common meningioma, thoracic is the most common area in 80% of cases. 80% are women. It is characterized by an ossified lobulated mass. According to the Simpson grading system, the range of the resection is determined. Schwannoma is divided into types 1 to 4 depending on the location, and all of them can be treated with the endoscopy. Features a jelly-like mass. Next is mixed papillary ependymoma. It is known to be more common in cauda equina and has a good prognosis after surgery. Like this, the capsulation is well done. Compared to open surgery, MIS surgery has many advantages. A lesser laminar removal can reduce tissue damage and no need for fusion due to lesser stabilization. Fecal return to function is of course. UV is a powerful endoscopic surgical method and is used in a variety of diseases. It is the most commonly used for HIVD, spinal stenosis, and spondylolisthesis. It is rarely used for deformity and trauma, but is not used for spinal cord tumors. I think that UV is the best minimally invasive surgery for spinal cord tumor. Spinal cord tumor has been solved by open surgery so far and still far from endoscope because endoscope has many limitations. Therefore, endoscopic removal of a spinal cord tumor is challenging when compared to the open surgery. I solved this problem with a primary dural repair. Once I open the door, I have to lock the door at the end. But endoscopic dural suture is very difficult technically. The first step for conquering intradural region is the endoscopic dural suture. This is the case of a primary dural suture. A 61-year-old female patient visited our hospital with low back pain and bilateral radiating pain. On MRI, L4-5 central and both lateral recess stenosis were severe, so ULBD was performed. This is a video clip of a simple interrupted dural suture technique. Tear size is 6 mm. I am trying a simple interrupted suture with a 7-0 Prolam. I am tying with a non-sliding technique. After cutting, check if the watertight suture is done with a hook. The advantages of a dural suture are that it can overcome CSF pressure and has stability so that you can work quickly from the next day after surgery. Because there is no CSF leakage, deep infection, complication can also be significantly reduced. Why should we do endoscopic dural suture? The first is to close the incidental dural tear, and the second is more important. I want to close the dura after removing the spinal cord tumor. The surgical treatment principles to be considered for intradural lesions are as follows. First, the location of the lesion. Second, anatomical relationship with the surrounding structures. Third, complete resection of the lesion. Fourth, safely excise without causing nerve problem. 5, keep stability. Finally, the meticulous dural suture. After solving the suture, which was the most troublesome, I thought that IDM was also worth solving. Let's see the case. 60-year-old male patient visited our hospital with bilateral upper extremity radiating pain. It was neurocranial grade 1. A 1.5 cm mass was found between C7-T1 on enhanced MRI. Removal was performed using UBE as usual. First, longitudinal durotomy is performed. Next, probing the mass carefully, make a tagging suture and expose the mass. This is the scene where the proximal end is cut. The distal end is cut too. Repair with a simple dural suture of 3 point. Check that the suture is watertight. The first photo is opening dural and tagging suture. The second is showing mass. The third is the proximal end part. And the fourth is schwannoma connected by distal end. This is a picture after schwannoma has been removed and the pyramidal is visible in the subarachnoid space. It was finished with a simple suture and the mass size was about 1.3 cm. Histological biopsy result was a schwannoma. The mass was not seen and the symptom was improved. The surgical sequence is as follows. The first is making portals. 3 portals is needed. The second is unilateral laminectomy. The third is bilateral phlebectomy. The fourth is dirotomy. According to the location of mass, you can select paramedian or midline approach. The fifth is a tumor resection. The last is a meticulous dural suture. Conclusion, dural suture technique is essential for surgical resection of IDM. I recommend to practice various skills to dural suture. IDM is curable using UVE. Thank you for your attention.
Thanks for the nice talk from the Dr. Songjun Lee. Actually, this is really very nice talk. I have completed about more than 30 cervical UB surgeries, but I never think that I could have a try to remove a tumor using UB surgery. So I would like to say, I have to confess that this is really a landmark in UB surgery. So very nice, I have to say.